Dr. Pat McDonald is with us today from New College in Florida. He grew up in, has anybody heard of Ohio? Where's that? Okay, yeah. Actually, has anybody heard of Newark, Ohio? Or as it's sometimes locally pronounced with just one syllable, yeah, Newark, Ohio. He went to a little school here in Ohio called the Ohio State University.
Just a little one.
Little? Oh, just order and a half of magnitude larger than Wittenberg. And then went to a much smaller school, but one perhaps a little more famous, the Massachusetts Institute of Technology, otherwise known as MIT. He is, by pedigree, a mathematician, but he's been lured over to the dark side, in part because he was willing and got strong-armed into it, actually, by a visitor with some clout and then the state legislature, and they said, you shall start a program on data science. And so even though he's into differential geometry or something like that, he said, well, yes, I will. And now he currently is willing to run the data science program. If any of you are willing to take over that job for him, he'd really appreciate it. So he started in a postdoc back at the Ohio State University, and then decided he wanted to teach at a small college, which I think is a totally wacky idea. And he's been at New College ever since. New College is in Sarasota, Florida. It's a lovely place. And if you want to go there for a graduate program in data science, I think I know somebody who can talk with you about that. After the talk today, too, there may be an opportunity to have dinner with Dr. McDonald, and both for professors and for students. And it would be on Beth's credit card, so we're going to the Winds, and we're going to have some of those $200 bottle of wines down there, if you're over 21. So without further ado, I turn it over to Dr. Pat McDonald.
Thanks very much for that kind introduction and a chance to speak. I'm very excited to be back in Ohio, although it seems like roughly a lifetime since I've been here, you know. In fact, I find myself saying that a lot nowadays. And I think it has something to do with the fact that I spend a lot of time thinking about technology. We live in a remarkable time, and things are changing rapidly, really, really rapidly. And I think a lot of that change is driven by our kind of newfound ability to generate, collect, warehouse, and process data at scales that just, a few short years ago were just unimaginable. And there's a new vocabulary that's kind of arisen in this context, and there are certain words that get used all the time, and one of those words is data science. If you're going to give a talk that involves some type of application that involves data at scale, then I think it's incumbent on you to make sure that people understand how it is you're using these words. So I thought maybe the first thing I would do is say a little bit about what I mean when I talk about data science. So I have a short definition. It goes something like this. Data science is a collection of methods for extracting knowledge from data. And I wanted it to be small and malleable, but I wanted it to kind of communicate real information. For me, it's about method mostly. Now I can say a little bit more about those methods. I can show you the ubiquitous Venn diagrams. It looks something like this. A circle near and dear to my heart, by the way. So I'm a mathematician by training, but by nature also. And this means that maybe I'll say things that sound crazy and don't understand. You should stop me at any time during the talk to ask questions. Very friendly guy in general. And there's a computer science circle, and then there's a domain knowledge circle. And every application involving data science starts really down in this circle. And this is a talk that involves an application. So in order for you to kind of understand what it is that I'm going to tell you and what it is that I've done, I need to tell you a little bit about the domain that I'm going to work in. All right, so here's an outline of what I plan on talking about. First, I need to tell you a little bit about healthcare in the U.S. And once I've done that, it'll make sense, hopefully, when I tell you the problem I'm interested in solving, the 30-day readiness problem. In fact, hopefully it will make sense to you what I mean by a solution. It's not clear. It's not the standard kind of mathematical thing. And then my solution, it turns out, is a neural network built by some of the grad students we have at the college and a couple of faculty members. I want to give you an idea of why we built the network we did, some of its properties, how it performs, that kind of stuff. I want to keep the conversation not too technical. Yeah? So I don't expect that you know what a neural network is. I don't expect that you know how they get trained, how they get built, that kind of stuff. But I hope to kind of give you some feeling for some of the stuff that goes into the design choices along the way, especially in the context of the problem that I'm interested in. I want to discuss a little bit the performance of the network, how it measures up against stuff that's already known. And then I want to kind of discuss briefly, very briefly, I'll probably run out of time long before this happens, future work that my students and I are doing along the same lines. Okay, so let's start. I need to say something about healthcare in the U.S. So the first thing I'll say is it's massive, right? It's a huge social construct. And there are a number of ways that you might give meaning to what you mean by massive. One way to do it is by just talking about money. Yeah? And it turns out that if you measure healthcare in the U.S. by dollars, then the scale is trillions, and the gradient is positive. Yeah? So we spend a lot of money in healthcare, and we're going to spend more. The other way to measure how big it is via the number of lives that it touches. Right? So if you measure it in people, it turns out there's about 12.5 million people who work in healthcare-related industries in the United States. And it turns out the number of people served is much, much larger, right? So 2015, about 7% of the population was admitted for a hospital stay. And that's a lot of people, again, tens of millions. And that's just for hospitalization, not healthcare in general. Now this talk has to do with hospitalization. So I need to focus down a little bit on hospitals in the US and what's happening in them. So once again, it turns out they're an important kind of subsector of the healthcare industry, and they touch a lot of people and involve a lot of money. Okay. So there are about 900,000 beds available in the U.S. at any given time. I guess I shouldn't say it that way. There are 900,000 beds in the U.S. Lots of those will be filled. And if you look at the amount of money spent per year, there's about $1 trillion associated with running hospitals in the U.S. So again, the scale is enormous. Now, given that there's so many people and so much money involved, cost versus quality of care is a really well-studied problem. But it's not immediately obvious what you mean by quality of care, how you actually establish a metric. What does it mean to get good care at a hospital? Anyone?
You leave it eventually.
You leave it eventually. Aha.
Not
Okay, so, pardon me?
Not in a body bag.
Not in a body bag. Well, even there it's kind of weird because sometimes there are plenty of people who go to the hospital and don't leave it not in a body bag. But there's nothing that could have been done to change that outcome. So it's not clear that that means they got bad care. Okay? One way, though, one indicator that maybe something's wrong, certainly there should be some correlation, is you leave it and you're not gone long before you're back there. Okay? All right, so that's a way to kind of start thinking about what you mean by a problem with healthcare delivered by a hospital, right? So, and it turns out it's not a little problem. This particular metric has been studied in detail, especially when the government pays, right? So if you just restrict to people who are in the hospital and on Medicare, if you look at that number, which is big, right? About 20% of those people are coming back within 30 days. Okay? So this is billions of dollars, all right? And there's a real question about why they're coming back. Sorting out the reasons that this happens is not easy. There are many of them. Nonetheless, so here's a kind of image that's supposed to show you that there's some serious complexity involved in understanding hospital readmits, right? This one, so here's a picture of the United States that's colored by readmit rate. Yeah? So 16.7 to 18.9% is kind of the dark reddish reason. And look, there's not a whole lot of pattern here. It's hard to tell what's really going on. That's a ubiquitous feature trying to study this problem, okay? The patterns themselves aren't clear. There's lots and lots of complexity in figuring out what's going on. Right. There are many, and part of the reason that's true is that there are many factors that lead to readmission. Some of them are on the patient side, right? Simple things you might think, like the inability to comply with post-hospitalization care. You know, you get sick, you go to the hospital, someone tells you, okay, well, you got to do the following 6 things. One of those involves buy some medicine that you can't really afford. Another one involves take some time out of your day that you can't afford because you take care of other people, et cetera, et cetera, et cetera. When you relapse, whose fault is it? Well, that's a really tough question to answer. It's not clearly the hospital's fault. It's not clearly your fault, right? There's also just the refusal to comply with hospitalization care. So, you know, I mean, the last time I went, they told me, you must stop grappling. But that's just not going to happen, you know? I mean, I have this kind of obsessive-compulsive disorder. There's no way that I'm going to listen to what you're saying. I may condition on it, but I'm not going to actually comply. And then some people just aren't going to get better, right? There's nothing that can be done. They're sick, and they're going to remain sick for the remainder of their days. And on the other side, on the hospital side, there are also kind of things that contribute to problems. A lot of times, I mean, very many people here spend time in a hospital. Yeah, okay, so a few of us, you know, most of us getting older, some of us before your time. It turns out that when you leave, you get instructions. And a lot of times, those instructions are not delivered by necessarily the doctor who you have a relationship with. And you're on your way out and things are rushed. The person who's giving you the information isn't delivering it in a way that you're processing the information, et cetera, et cetera, et cetera. You just don't understand what's going on. Now, there's some complicity there on the part of the hospital. They need to fix that, right? People need to understand. There has to be a way to make sure that they understand that something is amiss. There's also just a question of substandard care, and there are lots of possible sources for that. One that you might not think of immediately is, did it work? Yes, early discharge. You might have just gotten out before your time. And it turns out that there are many reasons that something like this might happen. But for me to explain why that's the case, I need to tell you more about how healthcare in the United States works. Right? Now, it should be clear that on the patient side, there are incentives for improving on the readmission rate, right? If you're a patient, you don't want to go back because it costs a lot of money. It turns out that that's also true on the hospital side, right? There are penalties for unplanned readmits. This is part of the Hospital Readmission Reduction Act. It's part of the law, part of the Obama administration of healthcare reform. Right? It says that, look, if you go to the hospital and you are discharged, and within 30 days of being discharged, you end up back in the hospital for a related reason, that hospital is going to suffer a financial hit. Okay? It's going to cost them money. And you might say, well, why is this? Blah, blah, blah. The answer is, look, I showed you that Medicare statistic that said there's a 20% reading rate. And now I've kind of hinted that maybe there's something to do with early discharge here. No one really knows for sure why any given person is coming back. But there are some perverse incentives to get people out early. Okay? Now, to understand those perverse incentives, you got to understand a little bit about how a hospital visit works. Okay? So you go to the hospital and what happens? Well, someone's going to ask you two questions right away. One is, what's your insurance? And the other is, what's wrong with you? Okay? And so a couple of things are going to get established right away, whether you're a privately insured or whether you have Medicare or Medicaid. International Classification of Disease Codes. Okay? And then you're admitted, and then other things start to happen. So someone's got to figure out what it's going to cost and who is going to pay. Okay? And so what happens in practice is the collections of ICD codes get grouped into DRG codes. So those are diagnosis-related groups. And those codes are also the payment, the reimbursement to the hospital for things related to that group of codes are all negotiated ahead of time with insurance companies. And the rate at which the hospital gets paid depends on the number of variables, including things like customary length of stay for the particular affliction you have. And so, you know, if you're there for some malady and you're supposed to be out in a week and you're not quite better, and they retain you, then they retain you at perhaps a lower rate of reimbursement. And that bed that you're occupying could have been filled by someone who's fresh in and paying more. So when I said that there are perverse incentives for early release, this is an example of what I'm talking about. Okay? They clear that bed early and fill it with someone else who's freshly sick, they get paid more money. And that leads to the 30-day readmit problem, right? So a lot of money rides on understanding when it's a good bet to release somebody, right? That's what I was trying to explain in the last slide anyhow. Okay, so the 30-day readmit problem says, given a patient history of discharge, is it possible to predict with quantified uncertainty whether the patient will experience unplanned readmittance within 30 days? Now, again, it's important. Lots of money, billions of dollars, ride on this question. And the reason is that there are penalties if you get it wrong from the point of view of the hospital, and there are benefits if you get it right. That's the reason I'm interested in kind of thinking about this problem. Actually, I'm interested because I'm interested in just improving healthcare. But the reason that the problem draws a lot of attention is the one that I just mentioned. Lots of money ride. So here, unplanned readmittance rate is a technical term. It's a publicly reported metric. I should say, by the way, if you decide you want kind of a closer look at these slides, there's lots of references in them. There's pointers to other material, then just ask and I'll have them sent to you. You can have them. So look, there are many, many, many variations on this problem. It's well studied. You can condition on a variety of different things. You could say, oh, okay, well, suppose we just study the problem for people who've had a heart attack. Right? There's tons of stuff done on that. Or suppose I'm just interested in understanding the details for a particular doctor. Or suppose I go back to the math and I'm interested in understanding this as a function of geometry. There's lots and lots of variations. There's tons of work to be done on the same problem. The problem that I'm going to think about is the hardest of them. That's the unrestricted problem. Okay. Right, so I guess if you're going to solve a problem, the first thing that you need to sort out is what does it mean to be a solution? So I gave you a kind of statement of the 30-day readment problem. What would you offer me as a solution? Yes?
Or like, what does a solution mean? Or
Yes,
like
essentially, what is a solution? Someone,
like reducing the rate of readmission? Like generally reducing the rate of readmission?
that would be an outcome, definitely. So if you could do that, that would be great, but you would have to somehow convince me that there's a way to do that.
I thought you were asking for the definition of a solution in this case.
Yeah, it's tough here because this is part of the drill, right? It's tough to say what you really mean by a solution because it's not a solution in the standard mathematical sense of the word solution. This is the kind of thing that drives a mathematician nuts, right? I mean, we're in mathematics for a reason. And it's because we really need or kind of enjoy a certain amount of clarity in what it is we're doing. And when you use a word like solution in this context, it's not really clear what you mean. There's no theorem that says this is the way it is. Okay?
Maybe a model to predict when would be a good time to release sufficient.
Right, so what you really want is some type of prediction algorithm, right? That's what we're really angling for, is a prediction algorithm. And once you say that, right, then you entail a lot of choices, okay? In particular, you've got to settle on some choice for machine learning. And there are lots and lots of options, and they depend very much, right? The design choices you make depend very much on the kind of structure of the problem you're trying to attack. Okay? But there's something more pressing, oddly enough, in this particular problem, right? So in this problem, it involves people's lives, their health, right? So it turns out that interpretability is really, really important. It's not good enough to generate a black box that gives a good prediction, right? Because for two reasons. The first is that I'm not doing this for money. I'm doing it because I want to make a positive difference. And that's only going to happen if people use the algorithm. Okay? And by people, largely what I mean is doctors. And doctors are not going to use an algorithm that they don't understand. That goes against their training. Why should they believe that some geek is going to be more capable of actually telling them whether or not a given patient should be discharged than all of their medical training? The answer is that doesn't make any sense. They're not going to think about that unless your result has an interpretation that they can understand and then accept. Okay? So adoption requires that you have interpretability. And it turns out that in some parts of the world, not the United States currently, but in the EU, it's the law. It will eventually, I think, be the law in the United States. So there's a law called the General Data Protection Regulation. Anyone familiar with this? Okay, you should get familiar with it. This is a big deal, right? It's not just about health. Primarily, it's about finance, right? So suppose I write a neural network that kind of decides whether or not you should get a loan for a house. Okay? And the network spits out the answer no. And then I say, sorry, you've been denied. Well, in Europe, you have to actually explain to the people how that decision was made. And the answer, my algorithm said, you're a bad bet doesn't cut it, okay? In fact, if your algorithm is consistent with a pattern of denying a protected class service, okay, then you're in trouble. You're going to pay a heavy fine. And those types of regulations are coming to the United States eventually. It's civilized. I think it's a great idea. It's something that, if you're in a data science class now or something like this is something you should think about talking about, because it has huge ramifications for how it is you actually do data science. Okay. All right. So there are two good reasons. So the other thing that you're actually looking for is some way to get a measure of uncertainty in the process. So if your prediction algorithm is something like regression, there are standard methods for producing control of uncertainty in your estimate, right? But if it's a deep neural network, it's less clear how you actually do that. This is kind of a active area of research. Still, I don't think there's any consensus on optimal methods for controlling uncertainty. So that becomes a serious question. Also depends on what type of information is available, what you're considering an instance. It turns out that that's an interesting, I'll mention a little bit more about this later. And in general, what does it mean to be an error bar if you've got some algorithm that's essentially a black box? Why this works. Sometimes I click it and it works, and sometimes no. Okay. I should say a little bit about previous work on this problem. I mentioned that lots of people thought about it. If you're really interested, there are a number of good surveys. There's a survey for pre-2011 work, and then 2011 to 15 things picked up. I think the latter paper is actually longer, has more stuff in it. These two together survey about 70, I think, 70 different approaches to the problem. The thing I want to focus on for right now is just the variation in what people actually study. So the first thing is that the data involved runs across many scales, right? So some of the studies involve hundreds of cases, other studies, millions. Second, I mentioned before that I can subset on disease. So many of the studies involve hearts, many of the studies involve lungs, very few studies involve unrestricted problems. There's a real variation in methodology employed. Most of the studies are regression, in particular lace regression. So this stands for length of stay, acuity, comorbidity, and emergency room visits. So those are four variables you might associate to getting into the hospital. It turns out logistic regression on those is kind of the single most popular way to think about making a prediction for this problem. There's also a real question of how you're going to measure algorithm performance. So I'll say a little bit more about this later, but area under the curve is, when I say things like area under the curve, does that, anyone familiar with this? Good? Okay, good. Better than I was when I was your age. All right. Good. All right, so look, there's some essential ingredients if you're interested in adding to the literature, right? There are at least three things you need. The first, you need data. So you've got to have people who give you data. It turns out I do have people who give me data. So the Florence A. Rothman Institute is a private institute that works on health records. They have a really interesting story, but it's too long to tell now. If you come to dinner, then I can chat about that and how it is that they gave me hundreds of thousands of digitized health records that were clean and usable. Sarasota Memorial Hospital. So these are three people who are connected to the Rothman Institute who've helped immensely providing data. Then once you've got data, you need people who actually do the work. And in general, that means graduate students and junior faculty. So in fact, there were two graduate students, Carlos Arias and Aaron Craig, and then a junior faculty member, a friend of mine, David Gilman. Yes. And then you need a place to actually do the work. So you need resources. And so I was promised I could have 5 minutes to sell my program. And that's what this third thing is about. Okay? So I wanted to say a little bit about the environment in which the work occurs, and that's our data science program. Okay? So there are really 4 defining features of this program. The first is that it's a public-private venture. So what we did was we got a collection of corporate partners who want to provide us with data, internships, and students. And those partners range over a variety of different fields. So Akamai is one of them. They route about 1/3 of the world's internet traffic every day. The Allen Brain Institute is another. So this is probably the premier place on the planet to study the human brain. Ancestry, Blackrock. So there are a couple of financial institutions. Blackrock is one of them. And what they do primarily is provide us either with data sets or with opportunities for our students. And then the idea behind the program is that we'll take their data and cut it up into bite-sized pieces, and we'll teach you technique. We'll teach you the methods you need to be able to use if you're interested in data science, but we'll do it in the context of actually solving problems. So the problems start out smallish. By the second semester, they're bigger. Maybe they take 7 weeks to solve a problem. By the third semester, they take all semester to solve a problem. And the fourth semester, you're not on campus. You're with one of our partners embedded in a paid practicum. Okay, so that's the idea behind the program. It's small and it's cohort-based. What that means is, so small means 15 students a year, and cohort-based means everybody does the same thing. And that's one of those serious design choices that you make along the way. The reason we did this is that we spent a year traveling around the country talking to players, what I'll call them, data science players, Amazon and Google and Ancestry and Akamai, et cetera, et cetera, et cetera. And what they told us, we asked them what they wanted in master's students, and they told us. And the single most important thing showed up in the huge histogram that we built was the ability to work as part of a team where your skills aren't replicated. Okay? This is the single most important thing. No matter where you go, no matter what you do, if you want a life in data science, you have to be able to do this. There's lots and lots and lots of stuff I can tell you later over dinner if you're interested along those lines. But for now, let me just say that being able to work as part of a group is essential. And it's a real skill, and the only way to learn it is working in groups. 555 here means the following. I said that it's small, we take 15 students a year. 5 of those are going to be people who have software engineering skills. 5 of those are going to be people who have statistical skills. 5 of those are going to be people who are just clever and interesting, right? So you don't have to be a software engineer, you don't have to be a statistician. You have to know linear algebra, and you have to be able to program. But besides that, if you do physics, if you do computational biology, if you do biochemistry, we have lots of students there who do biochemistry for some reason, I don't know, then we're interested, okay? The first 2 semesters. 4 courses per semester, split evenly amongst those 2 big circles. Yeah? Right. Good. And so here's how this project fit into the NCF program. FARI is one of our supporters. They're one of our original partners. They gave us all this data. Aaron and Carlos worked on the data during their first year, and then they got practicum experiences with FARI during their second year, so they were embedded in it. I should say that this stuff all appeared in a paper that was accepted by NIPS. So NIPS, so it turns out that conference proceedings for software engineering are the venue of interest, right? That's really, the big conferences is where you want your work published. And NIPS is the biggest one when it comes to neural information processing. So if you're interested in neural networks, artificial intelligence that involves deep learning, this is the big conference. Erin got her paper published. She just got a fellowship. She's going to finish her PhD apparently at Stanford. She's decided to opt out of business and into Stanford. If you're interested in the paper, there's a pointer to it. Okay. Oh yeah, and then one last selling point. This is a college. So this is what it looks like. It sits right on Sarasota Bay. You can go and see pictures of it online if you like, but it's a fairly spectacular place. Or you could talk to Professor Bitterman and Professor Andrews.
Are you actually in that building?
Yeah,
Or is that like how we
that's
show
where we had
everybody?
lunch. So this is where we met, right here, having lunch, yeah?
And if you were to the right of the picture, you'd be wet.
Yes, right here is the bay. So it literally sits, the college sits on the bay. Check it out, it's not cold there. Okay, so now I want to say something about the solution. I'm quickly running out of time. What I have until when do I have? I can't remember.
4:30.
Gotcha. Okay, so here's some of the information available. I've got ICD-9 and ICD-10 codes. I have personal histories and records of all these people I'm going to tell you about. I've got vital readings. I've got test results, and then indices, which are collections, weighted collections of test results and vitals. Then I have staff notes, doctor's records, things like that. And I have also the past performance of the hospital to keep in mind, all right? And so given that this is what I have available, I have to decide what kind of model I want to build. Okay? And the first thing I do is I kind of refine the question. And oddly, what I decide to do, and when I say I, what I really mean is Erin. She's really smart. What Erin really decided to do is let's just throw away almost all the data. Let's see what there is in the doctor's notes, the doctor's discharge notes. Let's see how well we can do with just that data. Okay? And there are a number of reasons to do this, and I'll explain that later. And I have to decide on some way to measure performance. In the end, you make a prediction. You want to know, why should anyone have confidence in that, right? So I need a schema. I need to be able to demonstrate that what I'm doing is good. Okay? So I'm going to use receiver operating characteristic and area under the curve to do that. So this is another kind of standard technique in machine learning to measure performance. And I need to somehow make sure that I build something that's interpretable. And I mentioned reasons for doing that. Now, given that I've decided somewhere in the background, so I mentioned that it would be nice to do a neural net for this problem. What that means is that I have to figure out an architecture for my network that's shallow versus deep. This is not going to be a deep neural network problem, because if I do that, I can forget about this. And then I'd like to know that whatever I build is actually extensible. I can use it to solve other problems at scale, etc. Okay. So I should say a word or two about neural networks. We made a decision to build a neural network. Why am I interested in such things? Anyone?
You can solve a lot of problems and make some really good predictions.
Excellent. It's like you read my slide. They work on hard problems. Here are some examples where that's the case. Right, so ImageNet, right? ImageNet recognition problem. I think they're thinking about actually shutting it down now because neural nets always win. Right, so image recognition is done very well nowadays by neural nets. Then there's drug design. So in 2012, Merck ran a drug design contest. It turns out the winner was a neural network. Speech recognition. Yes. Neural networks do an excellent job with speech recognition. Turns out that that's not such. This is the one that really kind of convinced me that this is what we should look at, given that you're going to look at doctor's notes. And then there are other examples where it solved tough problems. Watson, AlphaGo, these are all network-based solutions to tough problems. If you're interested in seeing more, there's online resources. right? So if you go to michaelnielsen.org, there's a kind of free deep neural network tutorial worth doing, an intro to neural networks. I'm not going to actually be able to explain to you what a neural network is in detail in the 1.5 minutes I've allotted to do that. On the other hand, I can give you some vague idea. So a neural network is a collection of artificial neurons arranged in layers connected by edges. Okay? And the idea is that I'm going to propagate a signal, an input signal, through the network by taking a weight, multiplying it by an edge weight, and then passing it to a node, and then doing that until I hit the output. Now at each node, I have a model that looks like this. I take a bunch of signals, weighted signals in, I sum them up, I feed them to an activation function. It tells me yes or no, something along these lines, yeah? And then it moves that output along its outgoing edges. That's in general how a neural network works. To train one, you show it an example. In fact, you show it penny. Yeah? And then you evaluate how it responds. And then you adjust edge weights to make it respond better. And then you iterate. And that's essentially how training a neural network works. Now, I didn't actually, so the fudge here was I didn't actually tell you how to adjust weights. It turns out that there's an algorithm for doing that called backpropagation. And it's really just an exercise in calculus and linear algebra. Okay. Which is one of the reasons that a little calculus and linear algebra is required for a program. Because I find myself saying that all the time. All you need to know is a little calculus and linear algebra. Okay. Now I can say a little bit about the neural network that we actually built. First, I should tell you about the data. So we had physician discharge notes for about 140,000 hospital visits over a decade in Sarasota. Turns out, oddly enough, Sarasota was one of the first places to standardize digital health records. We have a very deep collection of digitized health records. So we threw out parts of the data lest we do too good on our prediction. It's not difficult to predict whether or not a dead person is coming back. Likewise with hospice, release to hospice, right? If you release someone to hospice, you can predict pretty easily that they're not coming back, okay? And the machine will find that, all right? So we threw out these kind of cases because they just inflate our actual performance. This isn't done, by the way, in lots of literature, so go warily. And we did some pre-processing, threw out names, threw out a bunch of stuff, standardized the size of the input file, et cetera, et cetera. And then we trained it, right? So we split the data set, this 141,000 stuff, modulo the omits, into a collection of training data, collection of validating data, and then the test data. Right? So you train on 113,000 cases, you validate on whatever it was, 12,000 cases, which means you kind of try to adjust for overfitting using these 12,000 cases. And then you set aside 15,000 to actually run tests on to see how you do. Okay, so look, I've got only a few minutes left. Let me say, there are some problems with our data. It all comes from one hospital, and that means there could be some bias. It's homogeneous, right? It turns out that Sarasota Memorial Hospital is a remarkably good hospital by national standards, especially when it comes to the readmit problem. The population is homogeneous. It's 90% white with a median age of 67. And it's public. Right, so these are all possible sources of bias in the interest of open disclosure I mentioned. Here's the architecture for the network. It's really shallow. There are only, there's an input layer followed by essentially 4 other layers. This is the output. So the first thing to do is to take the doctor's notes and figure out a way to embed them in some high-dimensional Euclidean space. Has anyone ever heard of Word2Vec? Word2Vec? Word2Vec is a package developed for natural language processing over the last, I don't know, 5 or 6 years. By now, it's well developed. And the idea is it will take words and it will embed them in some high-dimensional Euclidean space. And then you can use the geometry of the Euclidean space to cluster. That's the idea. So Word2Vec allows us to dump stuff to Euclidean space and then find clusters. And those clusters we just assume will have meaning. And then we dump that to a convolutional, one-dimensional convolutional problem. So this is, look at trigrams and we convolve on trigrams. And that gives us like 250 features to think about. And then we collapse those features in a global max pooling. So if you think about this in terms of a data frame, 250 columns, a bunch of rows, what we're going to do is just max each column. That's what the max pool does. It's a data compression layer. And then we dump the remaining signal into logistic regression. That's what the dense layer means. Yes. All right. Okay, so this is all implemented in Tensorflow with a variation of backpropagation to train the edges. If that makes sense, right? So it turns out Google released Tensorflow. It's a software package that allows you to quickly and easily implement neural networks, especially when they're shallow. What we're looking at, check out TensorFlow. All right, so in the end, the model produces an AUC of 0.7. How does that compare with everything else that's been done? Well, if you look at those 70 or so models that we reference in the surveys, their AUCs correspond to about 0.55 to 0.79. And in particular, LACE, which is by far the most popular model, does about 0.65. So this model, where you threw out everything except the doctor's discharge notes, actually performs significantly better than LACE. Here's a picture of the ROC curves. Right, so the one on top is the neural network that we trained. The one on the bottom is LACE. The idea is to have as much area under the curve as possible, and you can see this is consistently outperforming LACE. Right. Okay, so let me say a little bit about findings, and then I'll cut it off and let you ask a few questions if you like. So first, our results kind of suggest that there's a lot of actionable data. In fact, more than is usually used to make predictions, just contained in the unstructured doctor's notes. The other thing is that the model is completely interpretable. I'll show you a picture in a second, right? Which means that there's a chance we can get people to use it, all right? I'll show you in a second. So here's a typical output, right? Here's an example of a true positive finding. So you can see up here the probability of 30-day readmission is 0.58. I think we cut off at 0.5. So this is saying, yes, they're coming back. And then the idea is to tell people why you made that decision. The software, what it does is it goes to the doctor's notes and it highlights the things that were important in making that decision, right? And this says up here, readmission more likely is colored in pink and red, and readmission less likely is colored in blue. Okay? So things that were omitted, sections predicted by their absence were these blue things, which were readmission less likely. And then these things, it turns out, were important in deciding this person would be readmitted. And sure enough, yes, they were readmitted almost immediately. Right, so in this sense, we can tell you exactly why we made the decision. We can highlight in the text the things that are important in making the decision. And then you can give it to a doctor and say, well, you either agree or disagree, but here are the things that you might have checked along the way. Right? There's a ton of other work that we've got to do on this problem and others. In fact, we're going to use this next year for a big project, but I'm already 2 minutes over, so I think I'll just shut it down.
Thank you, and let's see what, let's give him a hand right now.